Welcome to Deep Dive Ortho. Today, we're getting to grips with the challenge that, well, it's incredibly common, but can be profoundly debilitating for our patients. Elbow stiffness and contractures. Just picture someone like Sarah, maybe a 50-year-old carpenter, someone active. She falls, fractures her elbow. 6 months later, the fracture's healed beautifully on the x-ray, but she can barely lift a cup to her mouth. And that's not just a clinical issue, is it? It's a life issue. It impacts her independence, her work, her quality of life. Restoring that function is just paramount. So today, we're diving deep into what Sarah's facing. Why is the elbow so prone to stiffening up like this? And crucially, how can we, as orthopedic professionals, best assess and treat it to help her get back to her life? Joining me for this deep dive is Prof. Mo Imam, whose expertise in orthopedic surgery is extensive. He has a real talent for distilling complex medical understanding into clear, practical insights for us all. So let's get started.
Thank you. It's a pleasure. And you really hit on such a vital point with that example, the elbow. It looks relatively straightforward, perhaps, but it has this inherent, almost frustrating tendency to stiffen after almost any insult, whether it's trauma, surgery, even some underlying conditions. And as you said, that limitation can just cascade through their overall upper limb function, making simple daily tasks incredibly difficult. It really does demand our close attention and a very structured approach. Understanding elbow stiffness. A clinical overview. Absolutely. So let's start right at the basics. When we talk about functional elbow motion, what are we actually defining? And maybe more importantly, when does losing that motion become, clinically relevant stiffness?
That's fundamental, isn't it?
Yeah.
So normal elbow notion, typically it's from 0 degrees extension, fully straight, to about 135 degrees of flexion. And then forearm rotation, pronation, supination, we're looking at around 50 degrees each way. But the real key isn't just those absolute numbers. It's what's functional, what you need for daily life. Morey and his colleagues famously defined this functional arc.
Right, the 30 to 130 range.
Exactly. Typically 30 degrees of extension through to 130 degrees of flexion. And for rotation, about 100 degrees total arc, 50 degrees pronation, 50 degrees supination. That tends to cover most day-to-day tasks. Now, the point where it becomes clinically relevant, where patients really start to complain, is usually when they lose motion beyond those thresholds. So an extension loss greater than 30 degrees, or if they can't flux beyond 130 degrees, that almost always causes functional problems. And it's really vital to recognize that losing flexion often causes much more significant dysfunction than losing the equivalent amount of extension.
Okay, that's interesting.
Yes, you might have a patient with a 30-degree extension lag who manages reasonably well adapting their movements. But losing 30 degrees of flexion, that severely impacts things like eating, washing, basic self-care, bringing the hand to the mouth. And it's an evolving picture too, modern life, using mobile phones, keyboards, touchscreens. These activities often need a greater flexion arc than perhaps we considered functional years ago. So that 130-degree flexion target has become even more critical.
That's a really crucial distinction, and the point about modern demands is fascinating. It does make you think about how our definitions need to keep pace with patient needs. Now, you mentioned the elbow's propensity for stiffness. It seems almost uniquely vulnerable compared to some other joints. Why is that? What's going on sort of under the hood anatomically and biologically?
It's a great question, and you're absolutely spot on. The elbow's notoriously susceptible. There's really a perfect storm of factors. Firstly, anatomically, it's not just a simple hinge. You've actually got three distinct, highly congruent articulations of the ulnohumeral, the radiocapitellar, and the proximal radiocama joints, all packed tightly within one synovial capsule.
So it's quite constrained.
Yeah, very. It's a complex, tight-fitting arrangement, which means it has very little tolerance for trauma or swelling. Unlike, say, the shoulder with its looser capsule allowing wide movement, the elbow's intrinsic stability makes it vulnerable. Even minor disruptions can kick things off. And that joint space itself is quite confined. The articular capsule, which should be thin and flexible, sits incredibly close to surrounding structures, ligaments, muscles, even the skin. So when trauma happens, you get bleeding, swelling. In this restricted space, the pressure rapidly increases, and that initiates this detrimental biological cascade.
Okay, so it's not just mechanical blockage from swelling.
No, it goes much deeper to the molecular level. In post-traumatic stiffness, we see really profound cellular changes. There's a significant drop in the synthesis of type 3 collagen. That's the stretchy type needed for capsular elasticity. At the same time, you get this overexpression of profibrotic cytokines and growth factors, things like TGF-beta1, transforming growth factor beta-1, and CTGF, connective tissue growth factor.
And these drive scarring.
Precisely. This molecular imbalance triggers a huge proliferation of myofibroblasts. These are cells that act a bit like fibroblasts and a bit like smooth muscle cells. They just churn out excessive scar tissue within the capsule. So the capsule becomes incredibly thick, fibrotic, much less distensible. It essentially turns into a rigid casing, physically restricting movement. So the key insight is, it's not just a physical response, it's this deep-seated biological predisposition. The elbow seems almost designed to stiffen after injury. 2. Unpacking the etiology, categorizing the causes.
That molecular explanation really clarifies why it's such a tricky joint. So when a patient like Sarah presents with stiffness, how do we start to categorize the causes? And what are the clinical implications of distinguishing those origins for our assessment and treatment planning?
Understanding the categorization is absolutely vital, yes, because it directly shapes our investigation and, crucially, our treatment strategy. One of the most useful frameworks is Mori's three-part system. It categorizes stiffness as either intrinsic, extrinsic, or mixed.
Okay, intrinsic versus extrinsic.
Right. Intrinsic stiffness comes from problems within the joint itself, intra-articular causes. That includes things like post-traumatic arthritis, where the joint surfaces are damaged after injury, primary osteoarthritis, inflammatory conditions like rheumatoid arthritis, or even joint infections causing cartilage damage. Other intrinsic causes might be osteochondritis dissecans, loose bodies floating inside the joint acting as a mechanical block, or articular incongruity where the joint surfaces don't line up properly, perhaps after a fracture malunion.
And extrinsic, that's from outside the joint capsule.
Exactly. Extrinsic stiffness arises from extra-articular causes, issues outside the joint proper that still restrict its movement. This covers things like contractures of the capsule itself or the surrounding ligaments, stiffening of nearby tendons, or even skin contractures, perhaps from severe burns creating inelastic scar tissue. A really significant extrinsic cause we see a lot is heterotopic ossification, or HO. That's where new bone forms abnormally in the soft tissues around the joint, creating a very definite mechanical block.
Ah, yes, HO.
Also, neural adhesion, where nerves get stuck down in scar tissue, can contribute. And extra-articular malunions, where a bone outside the joint heals wrongly and causes impingement. But the critical point for us clinically is that most post-traumatic contractures, they're rarely purely intrinsic or purely extrinsic.
It's usually a combination.
Usually, yes. It's typically a mixed picture. You'll have some capsular tightness, maybe some muscle shortening, and potentially some early arthritic changes or subtle incongruity inside the joint. So when we evaluate a patient, we absolutely have to consider both intra-articular and extra-articular factors. If we only address one part, say just release the capsule but ignore underlying arthritis, we won't restore full function. This understanding guides our imaging, our surgical planning. It ensures we target everything contributing.
That clarifies the classification beautifully. It really is about looking holistically, isn't it? So, beyond these broad categories, what are the most common specific events or conditions that actually drive the development of stiffness? Thinking about Sarah again, what's the most likely underlying cause for her?
Overwhelmingly, the most common driver is trauma and injury. It's almost a given that some degree of stiffness will occur after an elbow injury. And the severity of that stiffness directly correlates with how bad the initial insult was, and critically, how much of the joint surface was involved. So for Sarah, with her fracture, that's highly relevant. A complex fracture, or one involving a dislocation, carries a much higher risk of significant stiffness compared to a simpler injury. And this process typically unfolds through stages. First, you get bleeding in and around the joint, then swelling, edema, then granulation tissue starts to form, and finally fibrosis, that laying down of dense restrictive scar tissue.
And within that trauma context, you mentioned heterotopic ossification, HO.
Yes, HO is a major player and really deserves specific focus. It's this abnormal formation of mature lamellar bone within the soft tissues surrounding the joint. It creates a very real mechanical block to movement. It forms because of an upregulated expression of bone morphogenetic proteins, BMPs, usually in response to the inflammation and tissue damage from the injury.
And how common is it?
The incidence varies hugely. It can be as low as 1.6% in some injury types, but it can go up to a staggering 56% in others, particularly severe trauma. And certain risk factors really ramp up the likelihood. Things like the extent of the initial trauma, if there was a joint dislocation alongside the fracture, any surgery around the elbow, prolonged immobilization after injury, severe burns, and neurological injury.
Neurological injuries?
Yes, particularly traumatic brain injury. Patients who suffered both a head injury and an elbow trauma have an exceptionally high rate of HO formation, somewhere between 76% and 89%. It really highlights why those patients need extra vigilance from us. They're at the highest risk. Beyond HO and the direct effects of the trauma itself, other key factors include prolonged immobilization after injury or surgery. The longer the elbow stays still, the stiffer it tends to get. Also, multiple previous surgeries around the elbow can compound scarring. And while trauma is number one, we mustn't forget traumatic causes. Primary osteoarthritis, inflammatory conditions like rheumatoid arthritis, joint infections which can rapidly destroy cartilage if not treated urgently, and even congenital conditions like arthrogryposis or congenital radial head dislocation, which limit motion from birth. Each path is slightly different, but the end result is often that same clinical picture: restricted movement and functional impairment. 3. Comprehensive evaluation, clinical and radiological.
That's a really comprehensive list of culprits. So bringing it back to our patient, Sarah, when she comes into clinic with her stiff elbow, a thorough assessment is obviously crucial. Could you walk us through the essential parts of a really robust clinical evaluation? What are the non-negotiables we need to cover?
Absolutely. The robust evaluation starts even before we examine the patient with a really detailed history. This is where we need to dig deep. What was the mechanism of injury, if there was one? What was the initial treatment? Exactly when did the stiffness start? How long has it been there? What's its character? Constant, intermittent? Is it getting worse, better, or staying the same? And importantly, pain. We need to characterize the pain. Is it mid-arc pain? That might suggest something intra-articular like arthritis or cartilage damage. Or is the pain mainly at the very end of the range, suggesting impingement from osteophytes or perhaps stretching of tight soft tissues?
And other symptom.
Yes, we need to ask about weakness. Any sensory changes, especially numbness or tingling in the little and ring fingers, suggesting ulnar nerve issues, which are so common. Any history of infection is critical, as that changes everything. And we need to know about other medical conditions, neurological issues, congenital syndromes that might predispose them to stiffness. Then, moving to the physical examination, start with inspection. Look carefully at the elbow. Are there scars from previous surgery? Any visible deformity? Evidence of burns? Signs of active inflammation like redness or swelling? The most critical part is then precise measurement. Measure both active and passive elbow flexion and extension, and forearm pronation and supination. Always compare to the other side, the contralateral side, if possible, to get a baseline for that individual.
And you mentioned the feel at the end of the movement.
Yes, pay close attention to the character of the endpoint. Does the movement stop with a hard, abrupt block? That often points towards a bony issue, an osteophyte, HO, maybe a malunion. Or is it a softer, more springy or leathery endpoint? That suggests a soft tissue contracture, like the capsule or ligaments tightening up. We also feel for crepitus during movement, that gritty or clicking sensation, which might indicate degenerative changes, synovitis, or maybe even an unhealed fracture. And crucially, always perform a thorough neurovascular examination. Pay particular attention to the ulnar nerve. It runs right behind the medial epicondyle and is very commonly involved after elbow trauma or surgery. It can get trapped or stuck down in scar tissue.
Can you provoke symptoms?
Often, yes. Deep flexion of the elbow can sometimes provoke tingling or numbness if the nerve is tethered or compressed. Knowing the preoperative status of the ulnar nerve is absolutely essential if you're considering surgery. Any deficit needs documenting, and it influences surgical planning significantly. The biggest pitfall here is missing subtle ulnar nerve involvement before you operate.
That's a truly robust clinical picture. It's amazing how much you can map out just from the history and examination. But sometimes what you feel isn't quite enough, is it? What imaging studies are really indispensable for fully characterizing the stiffness and guiding treatment, especially for our audience here?
Absolutely. Once the clinical picture is clear, imaging is essential to define the underlying pathology. Plain radiographs are always the first step. Standard AP, lateral, and sometimes oblique views. These basic x-rays let us assess the overall joint alignment, look for joint space narrowing, suggesting arthritis, identify obvious osteophytes, check for heterotopic ossification, and spot any large, loose bodies inside the joint. It's worth remembering, though, that getting a good AP view can be tricky if the patient has a significant extension block. You sometimes have to get creative with positioning.
And beyond plain films, when do we need more advanced imaging?
For most symptomatic stiff elbows where you suspect a bony block, or if there are significant deformities likely needing surgery, then a computed tomography scan, a CT scan, is highly recommended. CT, especially with 2D and 3D reconstructions, and sometimes even 4D dynamic scans, gives us invaluable detail. It's brilliant at showing the exact location and size of osteophytes in HO, giving us a precise roadmap if we're planning surgery.
So it helps differentiate bony versus soft tissue causes.
Exactly. CT is excellent for distinguishing whether the main problem is bone-blocking movement or whether it's primarily soft tissue contracture. And that distinction heavily influences whether we might try non-operative treatment first or go straight to considering surgery. I'd say if you're seriously suspecting a bony block, a CT is pretty much non-negotiable.
What about MRI? Is that often needed for stiffness?
Interestingly, magnetic resonance imaging, MRI, is rarely indicated for stiffness alone. Its main strength in the elbow is looking at soft tissues like the collateral ligaments or assessing inflammation. But for the mechanical blocks typically causing stiffness, it usually doesn't add critical information beyond what a good CT provides. It's a common misconception that MRI is always better, but for stiffness, especially bony issues, CT is often more informative.
Okay, that's useful clarification.
And finally, if you suspect ulnar neuropathy based on the clinical exam, which, as we've said, is common, then electromyography, EMG, and nerve conduction studies, NCS, are crucial. Often combined with an ultrasound scan looking directly at the ulnar nerve as it passes the elbow. These tests confirm if the nerve is trapped or damaged and assess how severely. This comprehensive imaging approach is vital for making the best treatment decisions.
Minimizing the risk of stiffness?
That's a really helpful diagnostic pathway. Now, given how challenging established stiffness like Sarah's can be to manage, prevention has got to be key, hasn't it? What's the current thinking, the evidence, on the role of early mobilization in minimizing this risk?
You're absolutely right. Prevention is far better than cure here. And the evidence strongly supports early mobilization. There was a key study, the FUNCSI multicenter randomized trial, looking specifically at simple elbow dislocations. It clearly showed that starting early active mobilization as early as 2 days after the injury led to significantly faster recovery and quicker return to work compared to the traditional approach of immobilizing in plaster for 3 weeks.
Even though the long-term results were similar.
Yes, interestingly, at 1 year, both groups had similar outcomes. But in the crucial short term, the early mobilization group had better function and a greater range of motion. This really reinforces a fundamental principle for the elbow. Get it moving as early as is safely possible across almost all injuries and surgeries. Prolonged immobilization is a known major risk factor for stiffness. Early, controlled motion directly combats that. So for Sarah, if early mobilization had been possible and implemented after her fracture, perhaps her stiffness wouldn't have become so severe.
That's a very clear message for early action. It really highlights how important those initial management decisions are. Beyond early movement, are there other specific prophylactic strategies? Any pharmacological things we should consider to prevent stiffness itself or maybe complications like HO?
Yes, there are several other measures we consider beyond just early mobilization. Firstly, immediately after surgery, strategic splinting can play a role. For instance, splinting the elbow temporarily in full extension can help minimize bleeding and fluid leaking into the tissues, which helps control that initial swelling and inflammatory response. By dampening that initial cascade, we hope to prevent the downstream development of contracture. But, and this is critical, this is only safe if the elbow's bony structure and soft tissues are stable. You can't splint an unstable elbow in extension without risking further problems. It's always a balance.
What about things like CPM machines?
Continuous passive motion, CPM, is another adjunctive measure, often started immediately post-op, ideally used for maybe 3 to 4 reps. The theory is that the continuous gentle movement helps pump fluid away from the joint and surrounding tissues, controlling swelling and minimizing that early inflammatory hit. But again, it absolutely requires a stable elbow. Trying to use CPM on an unstable joint can be counterproductive or even harmful.
And for preventing HO specifically?
For HO prevention, yes, certain measures are often considered. Non-steroidal anti-inflammatory drugs, NSAIDs, like indomethacin, are sometimes used prophylactically. The evidence specifically for the elbow isn't as strong as for, say, the hip, but it's a consideration. Post-operative radiation therapy is another effective tool against HO formation. However, we have to be mindful of contraindications, particularly the risk of causing a non-union if it's used too soon after an acute fracture repair.
And steroid injections.
There's ongoing debate about perioperative intra-articular corticosteroid injections. While some studies explore their potential to reduce inflammation and maybe HO, other research has linked them to an increased risk of post-operative infection. So, that's a risk-benefit calculation that needs careful thought. Finally, prevention isn't just about the elbow itself. It includes good systemic management. For patients with inflammatory arthritis, controlling their underlying disease is key. For hemophiliacs, ensuring adequate factor replacement prevents bleeding into the joint, which can lead to stiffness. And for septic arthritis, urgent washout is critical to stop cartilage destruction. It's really a multi-pronged approach: mechanical, pharmacological, and systemic. V treatment strategies. from conservative to surgical intervention.
That's incredibly helpful. So let's say prevention wasn't fully successful or wasn't possible, and we have a patient like Sarah with established stiffness. When is a non-operative approach appropriate? What does it typically involve for us, and what are the realistic expectations we should be setting with patients?
Non-operative treatment is definitely the first line, especially for patients with milder contractures, usually defined as less than about 40 degrees of motion loss overall. It's also the standard initial approach for contractures that have been present for less than 6 months in adults. Interestingly, in children, we might pursue non-operative management indefinitely, as the remodeling potential is different. The absolute cornerstone of non-operative management is aggressive physical therapy. That means dedicated active and passive range of motion exercises. Ideally, this needs to be guided by a physiotherapist who really specializes in upper limb rehabilitation, working closely with the surgeon.
Should patients be doing passive stretching themselves?
We generally advise against passive stretching being done by others. It can be quite uncomfortable, leading to poor compliance, and sometimes it can even flare up inflammation if it's too aggressive. Patient-controlled active and active assist stretching is usually better. Splinting is a crucial adjunct here. There are different types. Static splints just hold the joint at its end range for a prolonged stretch. Static progressive splints, like turnbuckle splints, allow the patient to gradually increase the stretch themselves, often worn for maybe 30 minutes 3 times a day. Then you have dynamic splints, which use springs or elastic bands to apply a constant low-load stretch. These are often worn for longer periods, maybe 6-8 hours, frequently overnight. They can be a bit bulky and more expensive, though.
Do the different splints work equally well?
Static progressive and dynamic splinting have both shown good results, often achieving around 40 degrees of improvement in range of motion over time. Static splinting alone seems to be less effective, particularly for improving flexion. The key thing to stress to patients is that this takes time. Improvement can happen over 6 to 12 months, sometimes longer. It requires real patience and persistence. Treatment usually continues until they reach a plateau, what we might call a pending contracture, where no further gains seem likely with conservative measures.
Any pitfalls with splinting?
Yes, a critical one. If the patient develops any ulnar nerve symptoms, tingling, numbness particularly when using a flexion brace, the splinting must be stopped immediately and reassessed. That nerve is vulnerable. One of the most frustrating parts of this phase is simply patient adherence. It's a long haul, a marathon, not a sprint, and maintaining that consistent effort over many months is tough. Finally, manipulation under anesthesia, MUA, can be considered for early stiffness, usually within the first 3 months after injury or surgery, but it comes with significant risks: iatrogenic fracture, making HO worse, temporary nerve injuries, especially the ulnar nerve. We're generally very cautious about doing MUA more than about 8 weeks after the initial trauma or surgery because the risk of fracture increases substantially as tissues mature.
That's a very clear outline of the conservative pathway and the commitment required. So for cases where this proves insufficient, perhaps like Sarah, 6 months down the line with limited progress, how do we decide if and when surgery is the right next step? It feels like quite a precise timing call. For junior colleagues listening, what might be a red flag indicating surgery should be considered sooner rather than later?
It is indeed a timing decision, guided by several factors. The clear indications for surgery usually arise when a patient hits that plateau in their rehab, showing no further improvement after a solid go, typically 3 to 6 months, of dedicated non-operative treatment. Or if there's a very obvious bony block to motion visible on imaging, or in cases of congenital conditions that just haven't responded. And importantly, if the patient's lifestyle or job is significantly hampered by the stiffness, even if the deficit isn't huge by textbook standards. Sarah, the carpenter, is a perfect example of that.
Are there specific degrees of motion loss that trigger surgery?
Generally, yes. Surgery is often indicated if there's a flexion, contracture, or extension lag greater than 30 degrees, or if the patient can't flex their elbow to at least 130 degrees, remembering how important that flexion is for daily tasks. Regarding timing, we usually like to wait about 6 to 9 months after the initial injury or surgery. This allows the initial inflammatory signs of soft tissue healing to settle down. Operating once things are quieter often leads to better results and potentially less risk of recurrence. However, and this is your red flag for potentially earlier intervention, if imaging clearly shows that osseous deformities or impingement, like significant HO or large osteophytes, are the main reason for the stiffness, then early surgical intervention is often recommended. Why wait 6 months if there's a clear mechanical block that therapy alone won't shift?
Right, that makes sense.
Other crucial factors are patient-related. Significant comorbidities might increase surgical risk. And critically, the patient must be willing and able to commit to a very intensive postoperative rehabilitation program. The surgery is only step one. The rehab afterwards is just as important for success. And finally, of course, surgeon comfort and experience with specific techniques play a role in deciding which surgical approach might be best. But regardless of the approach, the core surgical principles remain. Utmost respect for the nearby nerves and vessels, minimize soft tissue damage by using defined surgical planes, and always critically assess fracture reduction if relevant, joint stability, and the range of motion gained during the operation.
Okay, so the decision for surgery is made. Let's dive into the techniques. Can you start with arthroscopic arthrolysis? What are its advantages, and where does it really fit in our treatment plan?
Certainly. Arthroscopic arthrolysis, or keyhole surgery release, has become a really valuable tool. It offers several distinct advantages over traditional open surgery. The key benefits are improved visualization inside the joint. You can see the pathology very clearly. It generally involves less scarring, carries a lower risk of infection, usually results in less post-operative pain and swelling, and often allows for a potentially faster recovery for the patient. There's even comparative data suggesting significantly lower complication rates, around 9% versus 18% for open surgery, and lower revision rates too, maybe 1.6% versus over 6% for open releases.
So when is it ideal?
The ideal indications are generally cases where there's limited bony impingement or where the stiffness is primarily thought to be due to capsular tightness. It's particularly good for patients who haven't had previous elbow surgery, where the anatomy is relatively undisturbed. However, we have to be realistic about its challenges and limitations. It is technically demanding. The working space inside a stiff elbow is very tight, maybe only 6 milliliters of volume compared to 14 in a normal elbow.
That sounds incredibly tight.
It is, and that significantly increases the risk of accidental damage, iatrogenic injury to the nerves and blood vessels nearby. The ulnar nerve and the radial nerve are particularly vulnerable during arthroscopy. It also becomes much more difficult technically if the elbow is already deformed from previous trauma, severe burns, skin grafts, bad rheumatoid arthritis, or if there's hardware in place from previous surgery or congenital deformities. It's also relatively contraindicated if you can't clearly feel where the ulnar nerve is, or if you suspect it might be unstable and could subluxate during the procedure. In those situations, an open approach might be safer.
What are the key steps during the procedure?
Key steps involve, first, a thorough exam under anesthesia to confirm the motion limits, check stability, and precisely locate that ulnar nerve. Patient positioning is usually lateral decubitus, elbow bent at 90 degrees. Careful marking of anatomical landmarks and portal sites is crucial. We then distend the joint with saline, injecting maybe 20-30 milliliters into the soft spot laterally. This pushes the capsule out and hopefully moves the nerves and vessels slightly further away from the instruments, although it doesn't change their distance from the capsule itself. The main goals inside are to debride fibrous scar tissue to improve the view, perform osteophytectomy, trimming bone spurs off the coronoid, the olecranon, and cleaning out the fossae, remove any loose bodies, and then perform a targeted capsular release, usually both anterior and posterior. Using retractors specifically designed for elbow arthroscopy is strongly recommended to help protect those vital neurovascular structures and improve the view in that tight space. And we must be particularly cautious if considering releasing the posterior band of the medial collateral ligament arthroscopically, because the ulnar nerve can sometimes be scarred directly onto it.
That's a very clear picture of the arthroscopic approach, its potential and its pitfalls. Now, for those cases where keyhole surgery isn't suitable, or perhaps not enough, open arthrolysis is the alternative. Could you walk us through the main open approaches? What are their specific indications, and how do we choose between them?
Exactly. When arthroscopy is contraindicated or likely to be insufficient, then open arthrolysis is our primary surgical option. This is often the situation when you have extensive heterotopic ossification that needs removing, or severe arthritis with major joint surface damage, significant muscle contracture, or perhaps existing metalwork or very distorted anatomy from previous operations. Open approaches are also often preferred for really long-standing severe stiffness, especially flexion contractures, where the elbow maybe only bends to 90 degrees or less. These cases nearly always require a very thorough release, including the posterior band of the MCL, and often a formal ulnar nerve decompression and transposition. Let's look at the main open approaches. First, the lateral column approach, often associated with Professor Mori. This is incredibly versatile and probably the most widely used. Its great strength is providing excellent exposure to release both the anterior and posterior capsule and deal with articular problems, all while carefully preserving the lateral collateral ligament complex, which is crucial for stability.
So it's a good all-rounder.
It's a very good workhorse approach, yes. It allows you to tackle pathology on both sides of the joint through one main incision. Patients typically gain a good improvement, often 40 to 70 degrees in their total arc of motion, frequently with slightly better gains in extension. Then there's the medial over-the-top column approach described by Hotchkiss. This one is particularly useful when the main issues are extrinsic contractures, perhaps calcification in the medial collateral ligament, and crucially when you know or strongly suspect ulnar nerve involvement. Its main advantage is giving very easy access to both the front and back compartments of the elbow, and it makes releasing and transposing the ulnar nerve very straightforward. The key here is meticulous protection of the anterior band of the MCL to avoid causing instability. Patients typically see gains of around 40 to 65 degrees with this approach. Next, the anterior approach, described by Urbaniak. This has quite limited indications. It's mainly for isolated flexion contractures where the patient has full flexion already and there's no significant posterior problem. It involves careful dissection between muscle planes to protect the nerves and vessels while accessing the anterior capsule for release and removing any anterior bone spurs or HO. The posterior approach is another option, useful for accessing both medial and lateral structures through two windows from the back. The ulnar nerve is always identified and mobilized, usually transposed anteriorly. Various techniques exist for managing the triceps muscle, reflecting it, splitting it, or working around it to get to the posterior capsule and the posterior band of the MCL. It's also the standard approach for interposition arthroplasty and often preferred if the patient already has a posterior scar.
Do you ever combine approaches?
Yes, absolutely. Combined approaches are often used. A common one we favor is combining the standard lateral approach with the minimal posterior triceps splitting approach. This gives excellent exposure to both anterior and posterior pathology through reasonably limited dissection and typically yields good results, maybe 55 to 60 degrees improvement in motion. Finally, just to bring it together, surgical algorithms like the one proposed by Nandi and colleagues can be helpful. They guide the choice based on the pattern of motion loss. Is it mainly flexion, extension, or both? Are there ulnar nerve symptoms? And critically, are osteophytes or HO major contributors? As a general rule, if significant HO needs removing, an open resection is usually preferred because getting large chunks of bone out arthroscopically can be very challenging and time-consuming. The guiding principle is always to choose the least invasive approach that allows you to fully address all the pathology.
That's an exceptionally clear roadmap of the open techniques. Beyond these standard releases, what about the more complex cases, particularly those with significant joint degeneration or really severe functional loss? What advanced surgical options are in the toolbox, and what are the considerations when we're balancing patient expectations against outcomes for these bigger procedures?
For those really challenging end-stage cases, especially with significant arthritis, we do have several advanced options. Firstly, there's ulnohumeral arthroplasty, sometimes called the outer bridge Kashiwagi procedure. This is an option for patients, often younger ones, with mild to moderate osteoarthritis or post-traumatic arthritis, whose main issue is pain right at the end of extension or flexion due to bony impingement. It can be done open or arthroscopically. The key step involves creating a window through the olecranon fossa posteriorly. This allows access to debrided spurs and loose bodies from both the posterior compartment around the olecranon and the anterior compartment around the coronoid, effectively decompressing the joint.
So it's like a debridement or a clean out.
Essentially, yes. It aims to remove the impinging bone to improve motion and reduce pain while preserving the patient's own joint. Next, for younger, more active patients with intrinsic contractures and more widespread arthritis, say, more than 50% of the joint surface destroyed, distraction interpositional arthroplasty is a valuable alternative to fusion or replacement. This involves reshaping the ulnohumeral joint surfaces and then placing a biological spacer like fascia lata from the thigh or an Achilles tendon allograft between the bones. Often, an external fixator is used temporarily to distract the joint slightly and protect the graft. The goal is pain relief, improved function, and preserving stability, but it's a complex reconstruction, and the long-term predictability can be more variable than joint replacement. Managing patient expectations here is vital.
And for older, less active patients,
For older, lower demand patients, perhaps over 60, with severe intrinsic contractures and arthritis where the joint surface just isn't salvageable, then total elbow arthroplasty, TEA, or elbow replacement, becomes a really transformative option. TEA can provide excellent pain relief and restore a very functional arc of motion. Studies have shown average gains from, say, 0 degrees of motion in a fused elbow up to 80 degrees of functional arc after replacement. Because stability can be an issue after the extensive release is needed, semi-constrained implants are usually preferred. However, and this is the major caveat, TEA has historically had high failure rates in younger, more active individuals, and it nearly always comes with permanent lifting restrictions, often around 5 pounds or 2 kilograms. This significantly impacts what patients can do, so it's really reserved for that specific older, lower demand group.
You mentioned external fixation with interpositional arthroplasty. Is it used elsewhere?
Yes. Hinged external fixation can be used as an adjunct in other situations too. Its main role is to provide stability when a very extensive soft tissue release needed to regain motion makes the elbow inherently unstable. The hinged fixator allows immediate controlled motion while protecting the healing tissues and preventing redislocation or subluxation. As mentioned, it can also be used to apply distraction across the joint during interposition arthroplasty to protect the graft. But it's important to stress if the elbow is stable after a standard contracture release without interposition, adding an external fixator generally offers no benefit and can actually increase complication rates. So its use needs to be very specific. Each of these advanced options targets a very particular patient profile and problem, underscoring the need for careful selection and experienced surgical hands. 6. Postoperative management and future directions.
It's clear that getting a successful surgical outcome is really only half the battle. Thinking about Sarah, our carpenter, after a successful release operation, what are the absolute cornerstones of effective post-op rehab? How do we ensure those hard-won gains in movement are kept and optimized? And what's often the most frustrating part for both the patient and the clinical team.
That's a crucial point. The number one goal of post-op rehab is unequivocally to maintain the maximum range of motion achieved during the surgery. And this has to start immediately. Aggressive, early active mobilization is key, ideally within 24 to 48 hours. To make this possible, excellent pain management is absolutely essential. Regional nerve blocks placed before or during surgery are often invaluable here, as they allow the patient to start moving without significant pain in those first critical days.
What does the rehab program look like?
It's a comprehensive program involving structured active and active assist range of motion exercises. The focus isn't just regaining the arc of movement, but also rebuilding muscle strength around the elbow and ultimately reintegrating the arm back into normal daily activities. It has to be an individualized program, tailored to the patient and the surgery performed. And patience is vital. While the biggest gains usually happen in the first few months, smaller improvements can continue for up to a year, sometimes even longer. The most frustrating part. As you asked, it's often maintaining that persistence. I often tell patients their elbow didn't get stiff overnight, and it won't become flexible overnight either. It's like trying to bend a piece of old, tough leather. It requires consistent, gentle, prolonged effort, not sudden force. Keeping patients motivated through that long process can be challenging.
Is splinting used after surgery too?
Yes, adjunctive splinting is often used if progress isn't optimal. Static splints, dynamic splints, static progressive splints, similar to the non-operative phase, can be employed to maintain the stretch, especially overnight. For example, someone with a significant extension lag might use a static extension splint at night. The role of continuous passive motion, CPM, after surgery is still debated. Some recent studies suggest it might offer benefits over physiotherapy alone for ROM recovery, but historically the evidence has been mixed and it adds significant cost. Plus, there are risks like nerve irritation or wound problems if not used carefully. And crucially, the motion achieved on the CPM machine doesn't always translate directly to the patient's actual usable range of motion. Ultimately, success relies on close teamwork, the surgeon, the specialist physiotherapist, and a motivated patient, all working together to adjust the program and push for the best possible outcome.
That's a great summary of the rehab phase, and the leather analogy really brings the challenge home. Finally, looking ahead, where is research heading in this field? What novel targets or approaches are emerging in the fight against elbow stiffness? What should we be keeping an eye on?
The future is quite exciting, actually, with research increasingly targeting the fundamental biology of contracture formation. There's growing interest in the role of specific inflammatory genes and pro-inflammatory cytokines. Identifying these as key players opens up potential therapeutic targets to actually prevent stiffness at a molecular level rather than just treating it once it's established. We know, for instance, that just remobilizing a joint after it's been immobilized can trigger inflammation and cytokine upregulation. So, finding ways to modulate that response is a key goal.
Are there specific drugs being looked at?
We are seeing early research into pharmacological interventions. For example, animal studies, often in rats, have shown that intra-articular steroid injections like triamcinolone can dramatically decrease postoperative stiffness. And it's a big, but translating that safely to humans requires much more research, especially regarding infection risks. Similarly, drugs like celecoxib and NSAA have shown promise in rabbit models, reducing scar tissue and improving ROM after induced arthrofibrosis. This hints at possibilities for systemic or maybe even local drug delivery to dampen down that fibrotic process.
Any other pathways?
There's been some research into mast cells, which are involved in inflammation and fibrosis. Studies using mast cell stabilizers like ketotifen fumarate in humans after elbow trauma haven't shown clear benefits so far. But animal studies are conflicting, suggesting we still need to better understand the exact role of mast cells in this specific context. It's clearly a complex biological process. Beyond drug targets, there's still a real need for more robust research to optimize our postoperative rehab protocols. We need good quality multi-center trials comparing different approaches like combining physio and CPM or looking at the timing of starting therapy, early versus slightly delayed. This will help us move beyond expert opinion and provide solid evidence to guide our physio colleagues. Really, the biggest prize for the future is figuring out how we shift from treating established stiffness to reliably preventing it in the first place. That would change the entire clinical landscape for these patients.
That's a truly insightful look ahead. It suggests the future involves tackling the biology just as much as the mechanics. We've covered a huge amount today, from the elbow's intricate anatomy and why it gets stiff, through the nuances of diagnosis to the whole spectrum of treatments, from conservative care right up to advanced surgery, all aimed at getting patients like Sarah back to doing what they need and want to do.
It has been an extensive discussion, yes. And it really underscores that managing elbow stiffness remains a genuinely complex clinical challenge. Our ultimate goal always is to restore an elbow that is pain-free, functional, and stable. As we've discussed, achieving that hinges on getting the diagnosis right and then tailoring the treatment individually, considering the cause of the stiffness, the patient's age, whether HO is present, their functional demands, their lifestyle. Techniques are constantly evolving, both arthroscopic and open, and they offer good outcomes. But finding the absolute optimal approach for every specific presentation, that still needs more high-quality comparative research to guide us even better.
This deep dive truly highlights how critical our understanding and our tailored approach are for really improving things for our patients. If you found this discussion insightful, we'd be grateful if you could rate and share this deep dive with your colleagues. Thank you so much for sharing your invaluable expertise and insights on this critical orthopedic challenge today.
It's been a real pleasure discussing it with you.
Join us next time on Deep Dive Ortho for another in-depth exploration of key topics in musculoskeletal health.